I am Dr. Riaz Peringatthudi, one of the MSc endocrinology students from University of South Wales. And thanks a lot for giving me this opportunity to present an impressive, an exciting review article on vitamin D testing and treatment, which was first published in 2019 in Endocrine Connections. As clinicians, as endocrinologists, we know that the vitamin D testing and treatment has been a subject of controversial scientific discussion. There are several reasons to it. The vast amount of vitamin D literature and the heterogeneous and partially opposed opinions and recommendations from various trials and guidelines. We need to understand why there is heterogeneous nature of these results. One of the reasons being is that there are two kinds of trials and results around us. One is the nutrient trials done and for the population, and also the drug trials for the vitamin D deficiency diseases and its treatments. Also, the cutoff, there can be varying discrepancies about the cutoff kept for the replacement therapy of vitamin D as well. So in the next few minutes, my goal is to update you guys on the clinical and nutritional vitamin D guidelines, which is nutritional and clinical. So that's going to be very helpful, and summarize the current evidences on the role of vitamin D for human health and its subsequent implication for patient care and public health issues. So before diving deep into the clinical evidences, we will revisit the basic knowledge about the vitamin D physiology. Vitamin D, the letter D is the fourth in the fourth sequence in the sequence of vitamin discovery. Main two isoforms of vitamin D are cholecalciferol, which is known as vitamin D3, and vitamin D2, which is ergo cholecalciferol. But the problem with testing vitamin D is that we have to look for one of the metabolite of vitamin D which has got longer half-life and also higher in concentration. So vitamin 25-hydroxyvitamin D, which is a product of the liver, which is coming out of the liver, has got higher concentration and longer half-life. And that is the best parameter to indicate vitamin D supply from all different sources in the body. And if you see the half-life, and it's got a longer half-life, about 3 weeks compared to 125 dihydroxyvitamin D, which is a second hydroxylation which happens in the kidneys, and the half-life is only 1 day. So that's one of the reasons why we keep testing 25-hydroxyvitamin D as a reflection of vitamin D supply and level in the human body. So if you look at the next slide about the vitamin D, you can see the vitamin D endogenous synthesis and metabolism in detail. So you can see that endogenous vitamin D synthesis occurs primarily through sunlight exposure, which produces pre-vitamin D3. It is hydroxylated in the liver and then in the kidneys, producing 125 dihydroxyvitamin D, the physiologically active form of vitamin D, which acts in target sites in bone and immune cells as well as in liver cells. Now let's see some of the clinical effects of vitamin D and various randomized controlled trial results to support our knowledge, and also the contradictory nature of the results as well, which will be an eye-opener. Vitamin D eventually has got effects on various organs including kidneys, intestine and bones, but at the end of the day, the effects that we are much worried about boils down to the calcium and phosphate metabolism. Nutritional rickets is characterized by bone deformities as a result of reduced apoptosis of hypertrophic chondrocytes in the growth plate and reduced mineralization. Additionally, it can cause developmental delays, muscle weakness, and in severe forms, severe heart failure, and cardiac arrest. In children, when the growth plates are open, it causes rickets, and in adult bone, it causes osteomalacia because of reduced bone stiffness and subsequently causing muscle weakness and bone pain. Now, let's see some of the randomized controlled trials result regarding vitamin D deficiency and treatment. We know that the treatment of vitamin D deficiency in rickets and osteomalacia causes improvement in bone mineral density. But the data from RCTs and meta-analysis on vitamin D supplementation in unselected population show either no or only slight increase in BMD. In subgroup analysis of RCTs, it has been documented that moderate improvement in BMD by vitamin D supplementation may be restricted to individuals with 25-hydroxy vitamin D serum concentration less than or equal to 30 nanomole per liter, with no significant effect at higher 25-hydroxy levels. On the other hand, vitamin D deficiency is not necessarily associated with rickets or osteomalacia, suggesting that other factors such as those related to phosphates and calcium homeostasis play a role and apparently determine the individual sensitivity to detrimental effect of vitamin D deficiency. Regarding the effect of vitamin D supplementation on falls and fractures, the current meta-analysis of RCTs draw inconsistent conclusion with either a neutral or small beneficial effect. Vitamin D has got loads of extra skeletal actions as well. These are all supported by cell culture, animal studies, and observational data. Very crucial for variety of common diseases including cardiovascular, autoimmune, neurological, infections, pregnancy complications, and cancer. But in contrast, RCTs have largely shown no effect of vitamin D supplementation on non-skeletal health outcomes. Having said that, some meta-analysis of RCTs documented beneficial vitamin D effects on certain health outcomes such as respiratory tract infections, asthma exacerbations, and some pregnancy outcomes and mortality. There has been several RCTs looking at the inverse relationship between vitamin D and cancer incidence and mortality. This talk will not be complete if I don't mention about VITAL trial, vitamin D and omega A3 trial, which looked at this inverse relationship between cancer and vitamin D concentration in the plasma. This trial was actually conducted in the United States, randomizing 25,875 old people who is receiving 40 international units of vitamin D was placebo. And they were followed up for a period of 5.3 median years. And the finding from the VITAL trial support a potential benefit effect of vitamin D supplementation on cancer mortality. But they do not confirm the reduction in the cancer incidence such as those for breast cancer that would have been expected from previous observational studies. Now, let's see some of the vitamin D guidelines available for supporting clinicians. Before diving deep into these guidelines, it's always helpful to know the difference between nutritional guidelines and clinical guidelines. The nutritional guidelines are targeted for general population, while the clinical guidelines are intended for patient care. Before going into the nutritional vitamin D guidelines, it's very important to understand certain terms used in the guidelines. The nutritional vitamin D guideline uses the terms the terms dietary reference intake DRIs or dietary reference values DRVs to describe the distribution of dietary vitamin D requirements in the population. These terms are very important and very essential for the use as a public health policy instruments. Next slide of mine shows the detailed definitions of various terms used in these guidelines. The first two are very important, so that I will read it out, and the rest of them you can have a look at later on. One is EAR, which is estimated average requirement. The average daily, which is the average daily nutrient intake level that is estimated to meet the requirement of half of the healthy individuals in a particular life stage and gender group. The second one is RDA, which is recommended dietary allowance. The average daily dietary intake level that is sufficient to meet the nutrient requirement of nearly all, that is 97.5% of healthy individuals in a particular life stage and gender group. So there is a lot of statistical analysis and data to understand the nutritional guidelines, but in simple terms, the summary of nutritional guidelines is that target serum of 25-hydroxy-vitamin D concentrations ranges from more than or equal to 25 to more than or equal to 50 nanomole per liter. This is corresponding to a daily vitamin D intake of 400 to 800 international units. That's what all we need to understand when you start interpreting nutritional guidelines. Now, next table, I will show you the various recommended levels of vitamin D as per various standards to prevent the nutritional rickets in the population, which is a self-explaining table with loads of information that you can have a look at later. So now coming to the clinical vitamin D guidelines, aiming to support the clinician to treat the vitamin D deficiency and complications. Things are slightly different, and it has to be understood in a different perspective and in an individualized manner. So let's look at few of the conditions and the recommended intake according to various. Regarding vitamin D supplementation of osteoporosis patients, the recommendations are not fully consistent, but 800 international units of vitamin D per day can be recommended. Higher vitamin D intake up to 2000 international unit of vitamin D per day may also be used in specific patients but do not represent the common consensus of major osteoporosis guidelines. Some experts argue that in older individual, that is aged greater than 65 years old, a general intake of daily vitamin D supplements with the 800 international units is a reasonable approach to ensure a sufficient vitamin D status. In chronic kidney disease patient, what we have is the guideline from KDIGO, Kidney Disease Improving Global Outcomes. And according to the KDIGO 2017 Clinical Practice Guideline, the vitamin D deficiency and insufficiency be corrected by vitamin D supplementation using treatment strategies recommended for the general population. So moving on to primary hyperparathyroidism. Patients with primary hyperparathyroidism and 25-hydroxy vitamin D concentrations less than 50 nanomole per liter should be repleted with vitamin D dose ranging from 600 to 1000 international units daily, aiming to bring 25-hydroxy vitamin D more than or equal to 50 nanomole per liter. A minimum, but a goal of 75 nanomole per liter also is reasonable. In primary hyperparathyroidism, it is also recommended to ensure a serum 25-hydroxy vitamin D concentration of more than 50 nanomole per liter. with a suggested supplement of vitamin D dose of 400 to 800 international unit per day. Now, so far we have seen the recommendations from Institute of Medicine in North America about the vitamin D replacement therapy for a population, identifying the risk and treating them to prevent complications for a population. Another set of guidelines what we have got is from the Endocrine Society. The Endocrine Society clinical practice guidelines are intended for patient care and vitamin D for treating vitamin D deficiency. The next slide will show a cohort of patients who are at the risk of developing vitamin D deficiency. So the Institute of Medicine in North America differs from Endocrine Society about managing this group of people. The Endocrine Society says that these patients should be actively screened for vitamin D deficiency, and whoever has got less than 50 nanomole per liter of vitamin D should be replaced to get it above 75 nanomole per liter. Also, the treatment dose of vitamin D deficiency according to the Endocrine Society is 50,000 international unit of vitamin D once a week for 8 weeks for its equivalent of 6,000 international units daily, followed by a maintenance dose of 1,500 to 2,000 international units daily. In obese patients with malabsorption syndrome, and particularly patients after bariatric surgery and patients on medicines affecting vitamin D metabolism, a higher dose, that is around 2 to 3 times higher, is suggested to treat vitamin D deficiency. Having said that, there is a big difference between the cutoffs and the treatment dosages in these dosages for various patients, and there's a big difference between both groups, IOM and Endocrine Society. There has been an intensive scientific debate on the difference in the recommendations regarding vitamin D requirements from the IOM report and the Endocrine Society clinical practice guidelines that we have already seen, and that is totally beyond the scope of this talk today. In simple terms, the IOM report does not conclude that there is additional benefit of achieving serum 25-hydroxy-vitamin D concentration of 75 nanomole per liter when compared to 50 nanomole per liter. Furthermore, whether or which difference exists regarding vitamin D requirement in general population and in certain patient population or at risk of individual is an unresolved issue. Let's move on and find out a little bit more of information regarding practical vitamin D testing and supplementation, and some information and evidences in regards to the level of toxicity. There is a general consensus that the low risk patients should not be widely screened and treated, even though Society of Endocrine has got a wider outlook on the low risk patients and who needs to be screened, as mentioned earlier. If you look at the evidences, no study has shown the effectiveness of 25-hydroxy-vitamin D screening in certain groups, so that any recommendations regarding 25-hydroxy-vitamin D testing have a relatively low evidence base and are mostly derived on expert opinion. Screening patients who are highly at the risk of vitamin D deficiency, rickets and osteomalacia is highly justified, and also in patients with the CKD and at the risk of getting hyperparathyroidism. One another thing that clinicians should be aware is that it's a very difficult thing to standardize the cutoff value for vitamin D because of a wide range of differences in among assays, and also inter-laboratory differences. So that will make things difficult to standardize the values, and the clinician should be aware of these vitamin D results as there are significant inter-assay and inter-laboratory differences leading to efforts for standardization and pressure toward well-validated gold standard measurements by mass spectrometry. There are seasonal variations of vitamin D in the blood, and all these things together make it very difficult to consider treatment for an individual. So this one another thing to note is that a patient who is you have started on vitamin D replacement therapy, a repeat vitamin D testing should not be done earlier than 8 weeks on treatment, because it is approximately the same the time required to reach a steady state. Some studies actually indicate that it may take even 12 weeks or longer to reach the steady state in serum. So 8 to 12 weeks for if you require a repeat vitamin D. There has been a question about intermittent vitamin D replacement and continuous vitamin D replacement therapy, and some of the data has been inconsistent. Some of the studies shows that there is an increased risk of falls with intermittent vitamin D supplementation. But if you look at the VIDA study, actually it did not report on increased risk of fracture or falls. In line with this, a recent meta-analysis of vitamin D supplementation and musculoskeletal health outcomes did not find difference for daily versus intermittent vitamin D doses. Some kind of caution can be advised when you are deciding about vitamin D replacement, intermittent or continuous therapy. Coming to the level of intoxication, there are different recommendations about it. Some of the trials shows that vitamin D usually can occur at a serum 25-hydroxyvitamin concentration about 375 nanomole per liter and is very rare. But the IOM report classified serum 25-hydroxy concentration greater than 125 nanomole per liter if sustained a potentially harmful. Still very unclear which serum 25-hydroxyvitamin D concentration should be used as a threshold level for vitamin D toxicity. Importantly, in the VITAL trial, there was no safety concern with regard to hypercalcemia, kidney stones, or kidney failure with a daily supplementation of 2000 international unit of vitamin D on a daily basis. So before concluding this topic, I would like to quickly navigate through the critical appraisal of vitamin D and research. One of the important facts that every clinician should keep in mind is that the evidences that we have generated for vitamin D replacement therapy for a drug and an individual should not be blindly applied to the nutrient trials, considering the major differences between nutrients and drugs. Also, we know that aspirin prevents lots of cardiovascular mortality and is proven to be beneficial, but we never give aspirin to a population very blindly. There's no blanket application of it. The same way, if we make a mistake of applying this vitamin D to the population blindly, the vitamin D will fall and it will stop as working as a wonder drug. For future management and research, there's a strong agreement among endocrinologists that a ricket registry should be developed based on standardized serum 25-hydroxyvitamin D and standardized case definition of rickets. Based on what all we have discussed, and this nice article has got some take-home points which are very useful for clinicians. The first point is that the vitamin D level of in between 25 to 30 is a risk factor for developing the complications of especially rickets and osteomalacia. So this population, these people should be identified and they should be treated. The effect of vitamin D on BMD and falls will be more evident on vitamin D sensitive individuals, and which means the people who have got vitamin D less than 30 nanomole per liter. The second point is that the meta-analysis of RCTs indicates that vitamin D supplementation may also reduce extra skeletal outcomes such as infections, asthma exacerbations, pregnancy outcomes, and mortality. But more data are required to clearly establish the causality here. Number 3, the clinicians should be very aware of this point, that the vitamin D testing should not be misused as a universal population-wide screening tool, but rather be applied only in selected individual at high risk of vitamin D deficiency. And fourth point, a reasonable approach for clinician is to supplement vitamin D in those individuals with measured serum 25-hydroxy vitamin D less than 50 nanomole per liter and osteoporosis patients. A supplement dose of 800 international units of vitamin D per day should be sufficient for almost all individuals to safely achieve serum 25-hydroxy vitamin D concentration more than or equal to 50 nanomole per liter, and to exert beneficial clinical effects according to some dose response analysis of RCTs. The last point the article put forward is that the article says, we believe, and I'll read it for you, we believe that upcoming large vitamin D RCTs will likewise not show significant beneficial effects as they did not target vitamin D deficient or sensitive high-risk individuals, but will provide important safety data for relatively high doses of vitamin D supplementation in the general older population. And with this, I'm ending my talk, and thanks a lot again for giving me this opportunity. And if you have got any more queries, I'm happy to answer during the coffee break. Thank you very much.